A lot of men think about prostate exams. They immediately think of the glove going on the hand of the physician and they immediately clench, but really trying to talk with them and discuss with them what some of the benefits are of understanding early detection, but even just having those conversations with their providers so that they understand what the risk and benefits are of having screening. And then really educating patients on what a PSA and a DRE actually are, like how it happens, what it shows, and what the necessary benefits of those are.
You're listening to the ONS podcast, where ONS Voices Talk Cancer, a resource from the Oncology Nursing Society. Through conversations with subject matter experts, we examine the important issues in oncology nursing, from new treatments to patient-centered research to advancements in clinical practice. Join us as we hear from nurses in all facets of oncology care, from bench to bedside and everywhere in between. Hello and welcome to the ONS podcast. I'm your host, Jaime Weimer, Manager of Oncology Nursing Practice at ONS. And today we're talking with Clara Beaver, Manager of Clinical Education and Clinical Nurse Specialist at Karmanos Cancer Institute in Detroit, Michigan, about prostate cancer screening, early detection, and disparities.
In this podcast, for the simplicity of conversation, we use the term man to refer to individuals who have a prostate or were assigned male at birth. This includes cisgender men, transgender women, non-binary individuals, and others who may retain male anatomical structures relevant to health screenings and evaluations. We recognize that gender identity is diverse and personal. Our intent is to be inclusive and medically accurate when discussing topics such as prostate health, cancer screenings, and other related care. It is essential that healthcare providers conduct comprehensive assessments that consider both gender identity and retained anatomical organs to ensure appropriate and affirming care.
This episode provides free NCPD contact hours. To receive credit, please review the episode notes for any guest disclosures before listening. Following the episode, complete the evaluation linked in the episode notes. Welcome and thanks so much for joining us today, Clara.
Thanks, Jaime. It's great to be back.
So to start off, what are some of the key risk factors for developing prostate cancer, and how can early detection affect outcomes for these patients?
Well, a key risk factor of getting prostate cancer is being a male and being over the age of 65. That's where a majority of our prostate cancers are found. There is a higher incidence in mortality seen in African American men, and a man's risk factor will also increase 2 to 3-fold if they have a single first-degree relative that has been diagnosed with prostate cancer, and that risk increases 6-fold if they have a second and a first-degree relative that's had prostate cancer. One of the issues with prostate cancer is that many of the men have no symptoms of prostate cancer, so early detection is an important step in treatment and diagnosis for these patients. Really, the men should discuss their risk and benefits of screening with their healthcare provider to find out if it's right for them.
So let's walk through what are the current screening guidelines, the current recommendations for prostate cancer screening.
So screening can vary on age and family history, but it still remains very controversial. The American Cancer Society and the U.S. Prevention Task Force really recommend that men talk to their healthcare providers about the risk and benefits of screening, like I already said. So the U.S. Prevention Task Force recommends men the age of 55 to 69, and the American Cancer Society recommends men age 50 with an average risk of developing prostate cancer and are expected to live for greater than 10 years. So the recommendations are men who are 45 that are at high risk, including African American men and men who have a first-degree relative that have been diagnosed with prostate cancer younger than the age of 65 should go through screening. And men age 40 at an even higher risk, and these are the men that have that one first-degree relative who've had prostate cancer before the age of 65. Screening includes prostate-specific antigen, or the PSA blood test, and a digital exam. So those are the screening recommendations, although they are a little bit controversial.
So let's talk a little bit more about those sort of screening modalities. How are the PSA testing and the digital rectal exams used in prostate cancer screening? How have those rules changed, either with newer technologies like MRI, certain biomarker tests, or as you said, that's sort of been somewhat controversial, and those recommendations and what to do and when to do it have seemed to evolve over time?
You still see PSAs and digital rectal exams as really the first line because they're easier for your primary care providers to perform, right? They do a blood test, they can do the digital rectal exam. There's really no additional screening that needs to be made. And those are typically covered by insurance. So they really still play that role in screening. But with the advent of MRIs and biomarkers, These have really helped really refine that screening process and determine treatment options for our patients. Again, those patients that might be at a little bit of a higher risk that could go for MRI or have biomarkers completed, or if they're like on that verge with their Gleason score or they're like in that gray area, instead of doing a biopsy, they may send the patient for an MRI or do biomarkers for that patient. These exams, the MRIs and the biomarkers, can really have those patients at more ease in that watch and wait category, which a lot of our prostate cancer patients get put into when they're at a low grade of prostate cancer. So when we have these updated technologies, it puts them a little bit more at ease that someone's watching what's going on and they don't have to have anything that is invasive done to see where they're at with their staging.
And that's so important. And we know there's no perfect screening test. There's risks with every screening test. Things like false positives, false negatives, and over-diagnosing, over-screening. We know that any screening test is not perfect. So what are some of the limitations with the screening methods that we usually use for prostate cancer?
So with PSAs, it can be high with patients that have BPH or benign prostate hyperplasia, or if you have a prostate infection or inflammation, your PSA levels can be high. Same thing with digital rectal exam. If there is BPH going on with the patient or they have an infection or inflammation, the prostate could feel a little different to that provider where it may alert them that maybe there's something going on. So again, if we screen the patient during these times, they may have a false positive exam and we may have to do unnecessary biopsies or expensive workups on these patients that are really just having something going on with their prostate.
And I think that goes back to, some of your original recommendations is that really it should always be a discussion with the patient, with their healthcare provider to understand, what are some of those potentially confounding factors that they need to take into account when they start screening and sort of how they approach screening for every individual patient. Now, are there any patient populations where prostate cancer screening might offer only limited benefit, and why is that?
So if a man has less than 10 years of age to live, it's really not recommended that they get screening. And the reason is that prostate cancer typically grows very slowly, and the potential benefits from early detection and treatment most likely outweigh the harms that may happen to that patient, such as anxiety, false positive, unnecessary biopsies, and the risks of treatment if we do actually diagnose them. So again, it's those patients that have less than 10 years left to live related to some other comorbidities or other things that are going on. Screening may not be necessary for those patients.
What types of disparities exist in terms of patients being able to access prostate cancer screening, and what populations are most affected by these disparities?
Disparities in screening access exist based on race, socioeconomic status, gender identity, education, and geography. It's really hard in rural areas to get providers, primary care providers, or urologists that can actually see these patients, sometimes in urban areas. So again, socioeconomic status also can affect that, but also where a person lives. African American men with lower incomes and people in rural areas face the greatest barriers to receiving screening. It's also important to encourage anyone with a prostate to be screened and offer gender-neutral settings for patients to feel comfortable.
Now, how do programs like Medicaid or other public health programs influence this access to prostate cancer screening? And even with those programs, are there still gaps in care when that coverage is available?
So luckily, Medicaid and Medicare do cover PSA screening and digital rectal exams, but there really continues to be that barrier of lack of facilities that provide screening, knowledge gaps on the providers about when and how to get screening, and lack of patient knowledge to have those conversations with the providers. And some providers have access issues to the patients to be able to actually do this. With the advent of telehealth, not all patients are coming in where we can do some of these digital rectal exams and things like that. So again, those barriers, even though Medicaid and Medicare cover it, which then usually the other insurance companies will cover, it's still hard to get patients into areas to get them completed.
That's so important that you brought up telehealth because it does have many benefits, but there are still some things that we literally cannot do through telehealth if it requires physical presence, physical touch, actual hands-on examination. And so you're absolutely right. Having it covered is one thing, but making sure the patients come in for that visit, know that they need to come in for that visit, having transportation, having access, a local provider to give that screening, all still things that aren't automatically solved for just because we have coverage by whether it's Medicaid, Medicare, or other private insurers. So how do you see us as oncology nurses? How can we help educate patients about prostate cancer screening? And how do we just overall play a role in helping patients to overcome the types of barriers that you brought up that might prevent individuals from getting screened?
Really just having those conversations with our patients about what conversations they should have with their healthcare providers about what screening they need to have. I mean, I know that a lot of men think about prostate exams. They immediately think of the glove going on the hand of the physician. They immediately clench, but really trying to talk with them and discuss with them what some of the benefits are of understanding early detection, but even just having those conversations with their providers so that they understand what the risk and benefits are of having screening. And then really educating patients on what a PSA and a DRE actually are, like how it happens, what it shows, why we do it, and what the necessary benefits of those are. As a personal story, my father was diagnosed with prostate cancer. His primary care provider found it during one of his health screenings. He does live in a rural area, so luckily I had contacts to be able to get him in to see our physicians and providers and be able to treat his prostate cancer pretty early. He did recur, and so he went on a clinical trial, but it just again shows how important it is, not only our patients, but our family members, making sure that they understand the screening that they need to have done as well.
That's such a great point. And I think as oncology nurses, oftentimes we are caring for patients that are past the point of screening for their specific diagnosis, if it can be screened for. And so many times we might not see that we have a role in sort of the prevention space of cancer care, but we certainly do. Whatever diagnosis we're seeing a patient for, it's not all of them. They don't have every cancer. And so there's still other screenings and things that our patients should still undergo, even if they're being actively treated for a different type of cancer. And as you just mentioned, our family, our friends, our patients' family and friends that come with them, we have sort of countless opportunities to reinforce the importance of getting routine screenings for any cancer that we can screen for. We have a role in that. And so I think today's episode and this brief discussion is just so important in reminding us as oncology nurses that we do have that influence. So we have that ability to share our knowledge and to hopefully provide that information to guide patients to the screenings that they need to hopefully catch things early and put them on the road to a better outcome. Clara, thank you so much for joining us today. As we get to the end of the episode, we like to always run through just a series of quick questions to help summarize some of the great points that we've talked today. So to start that off, how do you think healthcare professionals, how should we evaluate our own hidden or implicit bias that we might hold about prostate cancer screening?
As always, we need to ask ourselves what our biases might be. Many of our patients may have different lifestyles than us, and we need to make sure that we do not place our ideals on these patients, especially when discussing screening. It is also important to remember when screening patients to assess if they have a prostate. Any person with a prostate should be screened for prostate cancer.
What do you think are some misconceptions about prostate cancer screening?
I think a lot of men feel like they have no symptoms. They don't have prostate cancer. And if there's nothing wrong, I shouldn't do anything about it. So a lot of patients may put off screening because they feel fine, haven't had any urinary symptoms, doesn't run in their family. There's really no reason why I need to be screened because it's just not going to happen to me. So again, with prostate cancer, there usually are not symptoms that a patient's having. They may have maybe some urinary issues or some pain, but it's not very frequent that they have that. So just making sure that our patients understand that even though they're not feeling something, it doesn't mean that there's not something else going on there.
And what's something about this topic that's not often discussed, but you wish people knew more about?
I think we don't often hear about the barriers of getting screened. I think the shortage of healthcare providers in many areas, it's talked about, but maybe not as much in screening as just some primary health care for our patients. So if we don't have healthcare providers in the community that can provide the screening, the patients don't have the ability to get it. So I think that topic isn't discussed enough about how patients don't have access to the actual screening or the care that they need.
Absolutely. And I would just revisit, arguably, this is probably one of the cheapest screening modalities that we have. Like you said, it doesn't have to involve lots of big, expensive equipment, scheduling with certain sites that only have the machine that does the thing. Like this could be very simple, but it still has limitations and barriers. And so important that you brought that up. And I really appreciate you emphasizing that. Well, what do you think are some additional training or educational opportunities that oncology nurses should look for or explore to stay current on this topic?
As we know, cancer screening and cancer care is continually changing, and ONS really keeps up to date with those things that are happening. So ONS journals or education sessions by ONS, ONS Congress, ONS Bridge are great ways to learn more about that. or, just see what else is going on in your community. A lot of times you'll see urologists or oncologists going out and doing screening events or talking about prostate cancer in your community. So really just staying up on what's going on with the latest and greatest.
And are there any additional resources you'd recommend for patients or even other providers who want to learn more about prostate cancer screening?
So the U.S. Prevention Task Force and the American Cancer Society are really great resources regarding screening and what a Gleason score means, what prostate cancer is, what the screening and testing and everything is. I really recommend patients and providers look at those, especially patients, gearing them towards the American Cancer Society or NIH or any of their resources are great for them to learn more about their cancer or the screening related to their cancers.
Well, Clara, thank you again so much for joining us on the podcast today and covering this important topic. I appreciate your time and I love your expertise. Do you have any final comments to share with our listeners today?
Just want to say prostate cancer, if found at an early age, can be very curable. So it's really important for men to have those conversations with their providers about the risk and benefits of screening. And anyone that we can help along the way to be able to have those conversations, I think is a great thing for oncology nurses to do.
Well, thank you again, Clara. Thank you for listening to the ONS podcast. Tell us about your favorite part in this episode by leaving a review wherever you download your podcast. For more resources and information about oncology nursing, visit us at ons.org and ons.org/voice. The ideas and opinions shared in this episode represent those of the guest and not necessarily ONS.